this conference.
All right. So I was asking at the beginning, how are you guys feeling about your upcoming test? Is everyone comfortable and confident and just know we are going to nail this thing? Or are you having nightmares and dreaming of multiple choice questions? Okay, 150 questions, multiple choice predominantly. Some will be true and false, very few, not too many. And also matching questions. So you will have in one column a statement and you have to match it to its either to the right answer. Leonard, how does one try to put a bone back on their own? Yeah, so Sugenda, you will have to, so for example, find a match for a disease, for example, right? So I will list you a diseases and then you'll have to find what organism causes it. So it's 4 hours. It's going to be open on the 9th of July. And it's going to be open until 18th of July. So you have over a week. I included 2 weekends there for you to give you enough time to feel comfortable and not rushed. That said, once you start writing the exam, there is no breaking the exam. You have to finish it. Hi. Summer is lovely. So I sent you guys an email. I took a picture of of a boat, and as I'm looking through the pictures, I find that in the corner there, the name of the boat. I don't know if you had a chance to see that. So I see you guys were looking at the questions that we posted. No, no, it's not Mr. Poop. It's long-term care. Um, okay, let me share this with you guys. So if you look to this little boat that is just here in the corner to the left, it's it's called long-term care. I thought I was hilarious. Oh, yes, purchasing. Okay, thanks, Sharon, for reminding me. So I just wanted to talk to you guys about the questions that you've been through. Let me see if I can pull those up too. What did we call them? Fancy quiz questions. Yes. So share this quickly again. Huh. All right. So we had a question with regards to specimen for Legionnaire's disease, and most of you that answered the answer correctly. And when you get these questions, there sometimes there is more than one correct answer, and sometimes you will have an option to provide all the answers. However, when you don't have that option, always submit the one that is most appropriate. So we always think about, when we talk about Legionnaire's disease, yes, there is also the serology that we can submit and also sputums, but number one test that we are sending is urine. And then I have noticed that a lot of people struggled with the skin test. And so I posted additional materials for you with regards to TB. So this is going to be not on our test. I did not include any of these great TB questions, but you have to have a very solid knowledge going into your CIC exam about TB. And one of the major differences is latent versus active disease. So for latent TB, we don't isolate patients. So they're not symptomatic. We do these skin tests for your long-term care residents and also for staff in healthcare. So you will find every time you're getting a new job in healthcare, they will do a two-step skin test on you to determine if you have had any exposure to TB in the past. And then as you're working in the facility, in case something happens and you do get exposed, the secondary test is ran to determine whether you actually have been now exposed at work. So for any of the positive skin tests, so I posted that. I know some of you guys have responded to me. You were already reading it. I feel that most of you were surprised to find out about some of these ways the skin tests are interpreted. So just make sure you go back and read all these the information I posted for you. So it's actually a little blurb here that speaks about the indurations, and in particular in relation to the vaccine. So I know a lot of people think if they have had a vaccine, therefore they will have a induration after the skin test has been applied, and that's not necessarily something that by Canadian TB standards is actually considered valid. So anytime you have somebody that does test positive or has this induration that is over 10 millimeters, and even though they had the vaccine, the further investigation should follow. So you just want to make sure that any of your patients, for you guys in long-term care facilities, this is more applicable than the other people that work in acute care or in public health, we don't, unless you're working in TB department, you're really not following up on this. But for you guys in long-term care, this is important. So you want to make sure you test your patients. We don't isolate them unless they're symptomatic. So I think that's critical difference that you have to know and separate that. So as I said, this is not going to be on your on our test any discussion in any great depth about TB. There is some isolation questions and that, but not anything about these conversions. But for your CIC, you have to know what are the standards, who gets isolated, and what's the follow-up. And then there is this other one that I also posted for you, is this the serology test. So anytime you have someone that has been tested for PPD or skin test, and if they do convert and you have somebody who is testing positive, you want to follow up with serology. So those are those questions that I wanted to make sure we cover here from last week. And then I think there's a couple of things. It's just you guys have to read and get comfortable with the material. Most of you know what is incidence and prevalence. Everyone is comfortable around that. When it comes to CLI rates or any other rates that are specific to particular population, you always want to think about your denominator actually being focusing on that particular population. So, and the number of days that that particular device has been in situ. So if it's a ventilator associated pneumonias, you're counting how many days did we have these the ventilators in situ in ICU for, say, month of May, for example. So that's what you're looking at in terms of denominator. And then in your nominator goes the number of infections. And because these sample sizes are small, you're multiplying this by 1,000. So most of you got this right. It's just that I think we needed a little bit of finessing around that. And it's, again, just keep in mind that anytime you are looking into CLIs or any CODIs or VAPs, so that revolves around your devices or surgical site infections. So if you're looking at your surgical site infections, it has to be a match. It has to be, if it's a C-section, you're matching infections that are result of a C-section, and however many C-sections did we have in that over that same period of time that you're looking at. When you're doing your purchasing, always make sure that you have completed your investigation, and most of you have kind of been in that area, providing that as your first decision-making answer. What is important is that us as IPAC, we don't get involved in cost of the product when we are making recommendations. Usually we are aware, because if you're sitting on that either PESC or SPEC committee or whatever is that, however they're named, it's the product evaluation committees, they will have of course, cost presented, and cost is often a driving force in a lot of settings. However, when you as an ICP are asked to review a product, we are not evaluating whether this is a more expensive or less expensive product. It should not influence our recommendations. So I actually had a discussion with Sharon earlier, and I was saying, please remind me to talk about this purchasing. So in past, I had a very, very interesting experience. So we had a product. It was a good product. It's one of the best products on the market, and now was time to renew and renew the contract. At any time you're renewing contract, you have to open up for all available products on the market, and it's wise to review and go through the process. So somehow through this decision making, committee came down that they would be interested to review a different product that is on market, but they did not say we would like to investigate a number of different products, but they came with product B. So we had a product A in hospital, worked fine. There was nothing wrong with it. It's a good product, um, has good support from the manufacturer. We had a good relationship with their sales reps and their educating team. So they will come and provide education when needed. And so this new product to me came about to investigate. So of course I had to do the review. What is it? What's the active ingredient? What's the contact time? And then once you do that, you have to go back and look at the rest of the products that you could potentially have and provide different recommendations. So uh, when I reviewed everything that was available to us, the product B that was supposed to enter our hospital was actually not meeting the criteria. So it was not um, meeting any of hitting all the check boxes. There is product A that was already there, which did, and there is multiple other products that also could and were ticking all the boxes. However, this product B was not. And I had to write a report. I did also environmental scan, called the hospitals in the region that deal with, they have more or less same makeup like our hospital did, and look at what is that they're using in their hospitals. And nobody used this product B. So what happened, I remember it was July 1st as well, and I was on my holiday day typing away the report, wanting to make sure that this is out so everyone gets the fair set of information. What happened, the product was the cheapest product on the market, and not by a lot either. It was just a little bit less than our product A. So we also asked to meet with the rep and review the product and bring to do the trials. So when they brought the product in, the product that they brought in had expired and therefore had no scent. So in the long story short, they decided to go with product B, brought in product B, started using product B. We ended up hospitalizing few of our staff because they had allergic reaction to it, and not to actual product, we learned later, but actually to an additive that is put into this chemical to make it stable. So they did not want to work with us to actually reveal what are the active ingredients and what is hospitalizing our colleagues, to a point that we could not use it to clean when we had C. diff on the units. So we had to go out back to product A and purchase product A out of the contract. We had to break the contract with the product B, and so the hospitals get penalized when you break these contracts. So 3 of our staff were severely allergic. One's life was actually hanging by a thread in ICU. That person, every time she sees the sees the packaging, I think she was having a PTSD, honest to God. And so lessons learned is, doesn't matter. It was only a couple of cents of difference, but our product A actually came about and provided support and came in and replaced everything and put their product back on. Of course, they have benefits from it too, and we were paying much more at this point because we have to honor product B, the original contract, and also purchasing additional product now that we need to actually function without harming patients and staff. So something to think about when you are purchasing and involved in evaluation of products is always to think about the side effects and consequences. I could not include that because it was no evidence previous, because no one had that product in their on their shelves. And then as a result of that, what actually happened, it became a well-known story across the IPAC teams. So I actually had a couple of people reach out to me telling me how this product B tried to sneak kind of through and push out the product, whatever they had, same like us or something different, because of the cost. And cost always wins in on the of course on the market, but should never be a deciding factor and sole deciding factor for us as IPAC. So there's a lot of things to look and think about. So that's what I wanted to share with you, as there is my bad story and my bad experience with purchasing. And sometimes, you just want to go around and say, I told you so, but it's actually really bad to see your colleagues suffer in such a way that they end up in ventilated in ICU because they had such a severe reaction to a cleaning agent in hospital. So moving forward, so you all got this right for the diagram. It is a fish bone diagram. So everyone got that right. Herd immunity, everybody knows. So no doubt about that. But the last question was, it's actually no calculation there. You just have to read the headings and look at the total number. So the question was, what's the total number with disease? So it would be your cases, right? So exposed and unexposed, so it's total of 23. And then if you're looking at patients who are in row on the top row, those are the exposed. So you had exposed 15 positive, but there's also 7 people that were exposed, but they didn't get sick. And then you're unexposed, of course. There that in the second row. However, whether they're truly unexposed or we just don't know that they were exposed at this event, or maybe a secondary exposure, sometimes you don't have that information. But for your total of number of people with disease, just like you would call them when you are saying I have so many C. diff cases, it's the same thing when you're looking into your cases, right? So case is a positive, known positive person. So I hope that's kind of helped you with navigating through some of this questions. And then I also posted additional questions for you guys here under break and midterm. So there is your break and midterm. You can't access it. You can only see what it is. But under additional questions, there is some additional questions I put up for you. You can take a look at that. And so what I was proposing and asking is it something you would like me to do, to give you maybe an hour in next week sometime before you decide to write your test, to take a look, and maybe we meet for an hour, like an office virtual office hour, just to kind of hash out some of the questions that you may have. Okay. All right. So do you want to do this on Friday or Saturday? You want to do the same time next week? Friday. Yes, Friday. Okay. So here's what I'm going to propose to you. So you can read the materials, put some questions, because I'm sure there's going to be a lot of similar questions or questions that are somewhat in the same vein. So if you want to send me the questions as you're going through, and then I will provide like maybe just like a quick go through with you guys on Friday, 6:30 to 7:30, just to cover some of that is bugging you and it's kind of gnawing at you at the back of your brain, so we can go through that. Is that fair? Perfect. All right, so let's start with our antimicrobial resistance. So everyone ready to learn new stuff that you know? Okay. All right, so this class we will just talk about things that you, I'm sure, know, and it's just giving you a little bit of a different perspective. And then we are gonna go into antimicrobial stewardship. And I know that that's not close to everyone, so we'll get a little bit into that. But basically, we will just talk about, sorry, about what the antimicrobial resistance is, how it's developed, and what do we do to control it. So a little bit of a history. You guys heard me talk about Alexander Fleming. You guys know who he was. He was a biologist who developed the penicillium, or found the penicillium rather, discovered it, and used that to start developing, actually working on antibiotics. So what are the antimicrobials? So they're one of the most prescribed and used therapeutic drugs. Worldwide, it is a huge concern with use of these antimicrobials uh, because of the resistance that has developed over years, and it's still going strong. For in recent years, we started looking into developing antimicrobial stewardship programs and teams that work in managing the use of antibiotics inside the hospitals predominantly. There is some of these programs do reach into community. They're supported by government agencies. So we'll see a lot of materials that are handed out to your, general practitioners in community, family physicians, and such. There's also support and outreach to long-term care facilities and retirement homes, simply because even for the hospitals, it's a struggle to get the teams on. But it's harder, of course, in a long-term care settings. So that said, there is some programs that do support the pharmacists, and I put up also some of the free trainings for you as well. If you're interested to take a course, it's free, it's pretty cool. And there is also a tool that I actually will be sharing with you at the end of the class that you also may find handy. So what we do know is that antimicrobial use is responsible for the increase of resistance. So some of those, as you know, some of the bacteria themselves, they have pre-installed, so to speak, elements that are able to break down antibiotics. But over the course of time, due to use of, or an overuse or misuse of antibiotics, some of these microorganisms have learned how to break it down as well. So what is important when we speak about the resistance is that we say that it's not the person that is resistant to antibiotics or antimicrobials, it is the microorganisms that are. So we never say, and I know a lot of people, when we talk to them, our patients, they assume it is them who is resistant. It's not them. You guys know that. It's the actual, the microorganism that does affect our patients and residents. Okay. So for us, what's important to know from IPAC perspective is we always have been somewhat involved with reviewing and assessing the resistance of the microorganism from, and we can always look through it more kind of through a chain of transmission type of thing. But I think over years, and depends, again, I will say this, in my experience, depends on the programs, how strong the programs are. Sometimes you will be involved, sometimes you know somebody from your team who is involved with these antimicrobial stewardship programs. I've been involved with them, and rarely there was much for me to do except listen and learn and support them through education and developing some of the materials. But really, when it comes to decision making, because we are not the ones prescribing medication, we are not the ones providing medication, it becomes a little bit of a kind of more to the side, not really something that we are decision makers. But it's important that we have a table, a chair rather, at that table, because there is going to be time where we will actually contribute more. So we just have to grow and develop these roles more and find a way how can we participate in a more meaningful fashion. So for most of the times you will find that when you're looking into antimicrobial stewardship, they're always looking into this from a preventative piece and prevention first. So they're looking at how do we reduce the use of the drugs, perhaps, before they actually develop the resistance. So I actually have finally found my antibiogram that I had from many moons ago. So for you may find something like this. Let me just show you the right way up. I think this is the right way up. So something that looks like this, where it gives you a breakdown of the microorganism, gives you an amount of antibiotics that are to be prescribed based on either a body weight or however antibiotics are being prescribed, and also the adjustment doses that they are looking at. So you will see that some of these antibiotics we start them usually on IV, and we can move to oral antibiotics. So some of these things are good for us to know, but again, as I said, we are not getting involved in any of the decision making with regards to prescribing. I've been asked in the past, and I think, to be quite honest, I think people confused the role, thinking I'm infectious diseases physician, asking me about changing antibiotics. So I really we don't get involved with that. But you may be looking into something like the trends and maybe creating some of the reports, working closely with your infectious diseases physician and the pharmacist. So maybe working on some of that more of prescriptive pieces or advisory pieces and things like that. So in terms of terminology, what you kind of need to be familiar, and also
Sorry, Cornelia, just a question. Is everybody else able to see the screen? Because I just see a white screen. It's like very lagging.
Oh.
Now I showed up. Now it showed up.
I think it's just you.
Oh God, maybe I need to log out and log back in. I get to be the
You
lucky
had a
one.
problem with sound, right? Too. I think maybe
No, the
your
sound is
internet.
fine. The sound is fine. It's just I literally can't see the screen. Okay, I'm gonna exit and come back.
Okay. So for the terminology, what is important for you guys to know is just to know some of the definitions, and they may come up on your CIC exam. And again, no one's going to be asking you in any great detail to talk about antimicrobial stewardship or what particular antibiotics would be using, but just know about the program, know about who is involved, and just know the basic terminology. Okay. So antimicrobial, which means that it kills microorganisms. I'm just gonna mute Jagdeep here. She's too loud. So it could be antibiotics, could be antifungals, and could be antivirals, of course, depending on what we're treating. And then when you get into antimicrobial resistance, that's ability of a microorganism to overcome the antimicrobial. So the ability of the microorganism to fight off the drugs that we're using. With multi-drug resistant organisms, I think this is where a lot of people kind of get into this a little bit uncomfortable zone, not really understanding. So your multi-drug resistant organisms are the ones that show resistance to more than one drugs. So you will get on your result, the lab result will actually list all the antibiotics that they are resistant to. And then, of course, as a response to that, we create these programs that are designed to fight the resistance. So that's with selection of the drugs, the dosage, and duration of the treatment. So over the time, what has happened, we have learned more about the antimicrobial resistance and how it comes about. Usually, we think it's something that's new or we had influence through certain behaviors, and in part that's right. However, it is a naturally occurring phenomenon in the microorganisms, which is also elevated with overuse, misuse, and inappropriate use of antibiotics. So there is already a predisposition in a microorganism to have ability to fight the antibiotics or antimicrobials, and then through the way we were prescribing or using, we have enabled them to develop stronger resistance. So those are kind of just a little bit of a how this works on a broader view. Um, Also, what's important is how do we deliver the antibiotics in the healthcare? So, is it IV antibiotics? Is it oral antibiotics? And what's the length of the use of antibiotics? Um, as a result of overuse of antibiotics, we end up seeing our patients with prolonged hospitalizations. One that comes to my mind immediately is, of course, C. diff. Everyone knows the moment our patients get C. diff, they're longer admitted into the hospitals, they need more care. Some of these cases are beyond recovery, sadly, and sometimes we end up with patients that had to have surgeries to remove parts or entire colons for them because it has done so much damage to the C. diff has done so much damage to their bodies. A couple other things also that come to mind would be TB and use of antibiotics there as well, and also with some of these antimicrobial resistant microorganisms like gonorrhea and again TB. So those are the diseases that are coming to my mind when I think of prolonged hospitalizations and side effects that affect our patients' outcomes. So what's really important about these microorganisms is that they do have a tendency to affect, of course, the surgical patients, of course. So the ones, I think we discussed this briefly in the past, for the ones that tend to travel and bring stuff back to us. So if you know, there's a lot of countries that advertise, in particular, it's dentistry and plastic surgery. So, you know, I think Burnett knows somebody who went somewhere down south to get behind implants. So that's quite common for a lot of people because the surgeries are more affordable, and often people really not asking you whether you are meeting the criteria and are you a good candidate to undergo this surgery. So they just send you and you do your thing. Also, it's important to know that they do spread through the hospitals, through your healthcare facilities quite well. And the reason for it is that resistance alone. And also, it's something to keep in mind is that they cross now over border, of course, because of the travel. So some of the places that we mentioned in the past, that so one of the countries that I can think of that has done really amazing job in reducing their antimicrobial resistance is actually Israel. They've done a lot of work with regards to, in particular, CPE, but there's still a lot of countries that don't even touch it. It's just rampant in their countries. So and it tends to be with the countries that do sell antibiotics over the counter, and where is also the animal husbandry is not controlled. When you're looking into your mechanisms of action, so there's two different ways how microbials work. There can be either bactericidal or bacteriostatic. Cidal, of course, you guys know, it means that it kills the organism, and it does have the success rate of 99% of killing the organism. What static means, it just means that it slows its growth, and it does also have some of the kill characteristics, but it's not as successful as the bactericidal ones. So you've seen this before. I shared this one with you guys before. It's the mechanism of action. So the antimicrobials, they are designed to affect a certain part of the microorganism. So you would be looking into either attacking the cell wall or cell membrane or ribosomes, or going through the metabolic pathways. So, and on the other side, you know which ones are matching this particular mechanism. So you have your penicillins like your beta-lactam and vancomycin. I keep looking at these slides. They're all this look quite messed up. The letters are running off the screen. Um, so you're looking into your different types of antibiotics, so or antimicrobials. You don't need to know them by name, but only know some of them are specific. So you may be presented in your CIC exam with, there is ESBL, what are they? Or and they will give you a couple of options to pick what kind of mechanism they follow through, but you don't need to know the names of or classes of these antibiotics. So this is important when you are looking into managing the antimicrobials and ensuring that we have successful antimicrobial stewardship in place. So there is some of these measures that the pharmacist and your infectious diseases physicians are going through, and they're looking into the minimal inhibitory concentration, which is the lowest drug concentration that will inhibit the growth of the microorganisms. So when you're going through a process of a long-term treatment, they want to know the minimal inhibitory concentration, and also they want to know what's the half-life. So they know how to um, advise in regards to length of a treatment. So when a physician comes to your infectious diseases doc and asks them, what do you think? What should I do with this antibiotic? They are the ones who know all these details around the half-life. But we don't ever work with this. No one is ever going to ask you as an ICP, oh, what's the half-life of a certain antibiotic. However, it's important for you to know that this is what they're looking at and just the principle behind it. So for the half-life, it means that that's a period that a body requires to metabolize half of the drug. So that term is often used also when you're looking into toxicity, and you will find that in quite often mentioned when you're reviewing TB drugs. So that's one of the terms that you will come across as well. So the drugs that cause concentration, and if can develop the dependencies, you want to have a shorter usage than higher concentration recommended. And then with drugs that are like beta-lactams, they should have their concentrations maintained above that minimal inhibitory concentration, because once you have it above that minimal, you are ensuring the death of the microorganism. But if you drop below, you're actually encouraging the development of the resistance. So here is your penicillin. That's, of course, you guys know, it was the first antibiotic that was widely in use and started the use in 1940s. And there is a list of these that are in use, and you will find that they all have this beta lactam ring. And there is an image of beta lactam ring for use just because you need to see it. And it's actually a drug that possesses a bactericidal activity that inhibits the cell wall synthesis. So that's all you ever may come across in your CAC exam to know what is it. So just learn that little blurb and know that it's actually breaking down, inhibiting your cell wall synthesis. Natural penicillins, that's one of and the first ones that have been developed, but they're used against the enterococci, streptococcal species, and they still remain to be in use, although it's been such a long time, and is quite commonly prescribed against the group A strep. So here is your cephalosporins, 5 generations of them. Again, you don't need to know any of these names. Just get to know that if you come across a question, so you know, and it's kind of easy for them because they all start with this like ceph type 3 letters, 3 first sounds, so you know those are the ones that belong to the family of cephalosporins. And as they're going through and blowing through them, you have different generations, so you're just developing more and more, and you can see how and what are used to treat, but predominantly they're used for E. coli, Kleb pneumo, your 4th and 5th generation are, so your 4th generation used to be actually used for MRSA, can't be used anymore, and your 5th generation is also resistant to MRSA, or rather the other way around. There she is. Can you see us, Jagdeep?
Yeah, yes, I can. I had to reconnect because my Wi-Fi is kind of spotty.
Yeah, so I think somebody else also had a problem with connectivity, and I have advised them, if you can have a hard wire connection, probably better, because Wi-Fi can do that sometimes to us.
It's good now. So I was able to actually access the Adobe or the PDF file of the slides. So
Perfect.
while you're talking and I know you change it, I just go back and I look at that.
Yeah, that's smart.
Because I can hear you. It's just I can't see it. But it takes a little while. Yeah. I see it now.
Good. So the next one, we're going to be talking about your beta lactams. So those are the ones that you guys know. They're monobactams, and carbapenems are the other category. So under the carbapenems, you will find the imipenem and meropenem. So I'm sure you've seen them around in your charts. They're quite commonly prescribed, and they treat the streptococci, but they're not in use for MRSA. And then your ertapenem, it's also under family of carbapenems, and it's usually used for your gram-negative bacilli, and like your Pseudomonas aeruginosa and Acinetobacter. So when you find your ertapenem resistance, that's where you kind of get alerted, and you will find your results will say resistant to a list of microorganisms. And sometimes, the antibiotics, sometimes you will have entire rows upon rows of resistance. And then to make matter more interesting, sometimes these organisms that are resistant to a number of the newer developed antibiotics, they will actually be susceptible to something old school, and we kind of praise the God for that when you come across these results. But it's interesting. It puts a lot of pressure on the patient, but also puts a lot of pressure on the physician and the pharmacist to find the right treatment for the patients that are actually whose results are coming back with such findings. So your fluoroquinolones, you will also find these quite often prescribed. So, of course, I would say one of the most common ones I would find for Pseudomonas, it's been given ciprofloxacin, but also your Levo and Moxis, you will find them for strep pneumo and for Legionella. So they're quite commonly prescribed in the hospitals, in the healthcare. So this is not something you will not be familiar with. Again, no one's going to ask you what are we prescribing for this particular disease, because this is not in scope of our work. So just as I said, just kind of give you an idea what are we dealing here with. And then, of course, we continue with another category, the macrolides and lincosamides and streptogramins and what have you. So your azithromycin is one of those. Again, another one that is quite commonly prescribed. You find them quite frequently. I kind of find them anytime someone has chlamydia, I see those that are prescribed. So it's not something that is rarely used. They're quite commonly used. And then your clindamycin, of course. I find that clindamycin, you probably see a lot of that in your long-term care settings where you have a lot of aspiration pneumonias. Yeah. So you find those quite commonly prescribed. So again, your Genta, Tobra, and amikacin, so they're all still in quite frequently in use. The issue with them is that they do tend to have a toxicity towards kidneys, and also can cause issues with ears. So you will find that over extended use, or if it's the dosage is not right, you have to run the tests. Again, not you, the physicians will do this. You will find that they will be looking into the toxicity levels, and they will be sending blood samples to the lab to determine whether to continue with the treatment or change or adjust. So there is Vanco, of course, our good friend vancomycin. I'm sure you find these as well. So often people used to ask, can we get Vanco to treat colonizations for MRSA? And we strongly advise against that. And this is probably the only times that we do get involved with this. And I always bring our ID docs into this discussion. Again, it's not something that we can prescribe or not prescribe, but we can provide education around it. So if we decide to treat some of these colonizations, there must be a very, very good clinical reason for it. So in times when you have somebody who has been through numerous surgeries and has had numerous infections caused by MRSA, so those would be probably a good candidate to be decolonized. The problem with decolonization, yeah, so it's also, you also want, for vancomycin also is toxic, right? So you also want to run tests and determine toxicity in blood. So again, not something that we would be doing, you would be your physicians, but if you're asked, this is something to know. So it will actually build up toxicity as well. And then of course your rifampin, everyone who's ever seen any TB treatments, you know that's one of those drugs of choice. So you will find them in some of those patients, if you have in your long-term care facilities, if you have patients that had latent TB and such, you will find that they have been used. The issue again with this particular drug, and because of resistance of TB that's been developing and on a rise, you will find different types of cocktails, so to say, that are in use in addition with with revamping, of course. And then your metro, right? That's something that you, I'm sure, do see on a regular basis for C. diff. So those are all very, very strong drugs, and do have side effects, and it's a fine line how people are using these. Just so okay, so again, your antivirals, again, you don't need to know these. You'll probably are already familiar with some of them on your own. So you know that, for example, we use the oseltamivir for influenza. I find physicians are really not too quick to prescribe them. They're really, really good when you start them and early, and also really good in controlling and managing outbreaks. So if you're giving them preventatively, there is a different dosage for that, so your physicians know that, versus the prophylactic versus the treatment dose. And then, of course, the acyclovir, that's for shingles. You'll find that quite frequently in use. And your antiretrovirals. So with antiretrovirals, this is only thing that you need to know is what are they used for. You don't need to know how they function, how they work, but if you look into the principles, how they work, you will see that all of them are inhibiting one process or the other. So it's just, that's all you need to know, that they're working on inhibiting different processes in either establishing or starting up the process, or just slowing the process that is already in play. And of course, there's a bunch of drugs that are listed out there. You don't need to know any of these names of the drugs. So as I said, your acyclovir, you guys know it. It's used for herpes. You can use it like if often you will find if someone has a cold sore, they will get like a topical cream, or if it is like chicken pox. It doesn't really, I don't know that people are using this so much for chicken pox. However, for shingles, because the shingles themselves, they do have this side effect of very painful neurologic um, consequences after the shingles have kind of already passed and you are recovered. So that's when we start seeing that you would see that people are actually giving your patients acyclovir, is to reduce that post-herpetic neuralgia is called actually. And then also for your Epstein-Barr and immunocompromised. So acyclovir also you will see if you have, of course, any of your immunocompromised population. So that's quite commonly given to them. So it's probably one of those frequent drugs you come across. And then, of course, as I said, there is a bunch of the other ones here. So the oseltamivir is actually your Tamiflu. So in case you're asking and wondering what that is, what is one important thing for you guys to know is that it will have a side effect of diarrhea in some populations. So something to keep in mind if you see someone's given Tamiflu, just be alerted that this could end up with a diarrhea. So keep your eyes open on and your eyes peeled on that. I actually have not, and this is not something that's to say that it's not existing. It's just that it's not really in our scope of work. I know that with regards to the actual syndrome, caused by the vaccine versus a syndrome caused by influenza, then the numbers, the rates are much higher in population who has had influenza that has developed the syndrome rather than post vaccines. So, and as IPAC, we don't get to see these people. We don't get to see the stats because we are not the ones that are actually administering vaccines. We just provide the education around it, really. So I would not be the one seeing the stats coming back to us. So we continue with antiretrovirals. Yeah, so and it's just like one of those unfortunate syndromes that do happen. However, again, because of the media attention and focusing on this being a side effect of the vaccines, it has been more focused on in that correlation with the vaccine rather with an actual disease, and the numbers are much higher in diseases than actually with a vaccine. That is absolutely bogus. Yeah, we had actually a good discussion on our forum about some of the hesitancy, and there is a webinar coming up, and I want to send you also guys a link about the hesitancy in general population. So I'm just keeping my eyes open when that comes about to see um, how what is going to be a discussion actually about it. Is it something that is applicable to what we do or not? So I'll share once I get just kind of a little bit of abstract to see what's the discussion. So as I said, to your antiretrovirals, it's used for your patients that are infected with HIV, and it's always a combination of drugs. So December 1st is actually an AIDS Day, a World's AIDS Day. And you get, on December 1st, you will get a lot of free seminars and webinars leading to it and a lot of information. So I will just take a look if there is something that's still lingering around from that period, because it's a lot of good information that you get to hear about. But we have evolved as population. We have evolved medically and pharmaceutically with management of HIV and AIDS. So in the past, it would be a number of drugs that patients had to take. Now it's actually only a few pills that they have to take, and it goes below detectable levels. So they are quite, as I said, they're quite commonly used for the treatment, but also if you have any of the sharps or needle stick injuries, they are used also for prevention and prophylaxis in healthcare. So if you had a nurse that accidentally pricked themselves, or a housekeeper that was removing the bags and someone accidentally dropped a needle, a syringe into the garbage, they will always go to your occupational health and they will start them on these antivirals. And so with regards to your questions here, with regards to autoimmune diseases, so with regards to vaccines are designed to trigger our response and get our bodies to produce antibodies and go through the process of developing immunity. When you have people with autoimmune diseases, they're often treated with steroids, and which actually creates a little bit of a storm when you add a vaccine. So for people who are not on steroids and are just have autoimmune diseases, you will not find that they have such a strong reaction like the ones that are. So usually when you're recommending vaccines to, if you're involved with supporting staff, always send them to see their physician, especially if you have somebody with Crohn or any of your patients that, sorry, your colleagues that may be receiving the IV treatments of the drugs to suppress the immune reaction. So you want them to be definitely consulting with their physicians before they sign up for the vaccines, because it does cause a little bit of that immune response. But again, it wouldn't be the GBS. So, as I said, most of these antivirals, the antiretrovirals, are actually working as inhibitors. So, as I mentioned before, they're just kind of reversing the processes that are already going or stopping processes from happening in future. You don't need to know the names. You don't need to know any of that stuff. Usually the questions around the CIC is in relation to HIV and some of the other infectious processes, like it could be TB and things like that. Could be also some of these occupational health hazards that your colleagues may be exposed, and the recommendations around that. But you don't need to know how these antiretrovirals actually work. So it's more of that, again, the risk assessment of the process and how do we advise our colleagues. So your antifungals, again, it's still the same idea. It's in same line. We are trying to treat fungal infections in this case, but it's also either they are fungicidal or um, fungistatic. So you will find that there is different treatments for different diseases. Most common ones that you will find that is being treated is Candida. And for Candida, again, it's quite commonly found with the patient population that has immune system failure. So would be with your HIV AIDS patients. So not so much with HIV, but rather AIDS patients, you will find that Candida tends to take over. So again, some of these I'm sure you've seen. I've seen fluconazole quite frequently prescribed. So you'll just see them. People are getting them for fungal responses, fungal infections that could be present. In some cases, you will have also to see the imbalance between after a prolonged antibiotic usage, you will find that some of your patients will actually develop fungal infections. Other things also to be concerned with could be construction, and if you have a sensitive populations, like your cancer population, dialysis population, anytime you have any sort of construction going on. So this is something that you may encounter more of that. And then, of course, you guys remember from the previous lecture, the Cryptococcus, the dry fungus that was brought in from Arizona, and our Kitchener hospital ended up with demolishing and taking apart entire lab as a result of that. Nothing to do with the antifungal, just thinking about this particular fungus. So here is our lovely little parasite. So those are also something you may find. So chloroquine is something you would see used for treatment of malaria. That's the only one I have seen. I can't say that I've seen the other ones circulating in the patient's charts. This is the one that I have seen only. I only have seen some of the malaria patients that came. That would be the only parasites that I have. Nothing really exciting with these parasites. I always expect I'm going to find some worm hanging out of somebody, but never happened. So we're moving into our indications for antimicrobial use. Sorry, I'm just trying to catch up with what's happening here with the discussion, so I don't want to miss anything going on there. So this is interesting to know, and you will need to know the terminology and when are we using prophylaxis and prophylactic treatments. So it's quite commonly used in your surgical programs. You will find that the surgeon will start up the patient on antibiotics prior to the surgery. And this is going to be on your exam, these questions around the prophylactic treatments. It is usually in relation to surgeries that do involve um, prosthetic devices. So if you're doing any replacements like hips or knees, putting new joints in, so you will find that those will always come with prophylactic treatment, and it's always targeting the microorganism that could cause an infection based on the site. So if you're cutting skin, you expect to have some of those skin loving organisms, and therefore that's the antibiotic of choice that they will have prescribed to target this particular microorganism. You also may find this when they're dealing with some of those dirty surgeries where you have an accident where some like a car accident where a foreign object has penetrated into a sterile tissue, and before they are going to start a surgery, you will find that sometimes these patients will either roll into the hospital with antibiotics, sometimes not, depending on where you work. Again, if it's a trauma center, you will see more of this. If not, you will see a little bit more organized treatment and organized prophylactic measures. And then also, if you have something like appendix at birth and things like that, you will see that there are different types of antibiotic that are targeting these particular contaminants. And so the way they work, they will start your patient on a treatment to ensure that there is adequate levels of antibiotic in the tissue. So when they're cutting, there is, in case there is any sort of contamination potentially happening, this is protecting the patient through that first cut and to the end of the surgery. So sorry, I keep reading what's happening here in a discussion between Leonard with Black and Decker surgery. Yeah, so those would be the ones for sure. Anyway, so that's what you need to know is that we want to ensure that level of antibiotic is present in the tissue and throughout the surgery. So that's what you want to know with the prophylactic treatment. And they're deciding based on the site. So if you're looking at skin, they're targeting the skin loving organisms. If it's coming from the gut, so it would be the like E. coli and what already lives in the gut, so they would be targeting those type of organisms in this particular events. Okay, so when you want to discuss the empirical therapy, we are covering here the causative agents. So the ones that, like in particular, would be your broad spectrum if you don't know what you're dealing with. So you start off with a broad spectrum, and then as you're getting your information in, this may change, may stay the same, but most likely will actually change, because if you have a strong antimicrobial stewardship, they don't like us to use a lot of broad spectrum antibiotics. So it's most commonly used in hospitalized patients, of course. And the process around it is, you want to collect the blood specimens before you start the treatment. And you want to collect minimum of 2 different blood specimens for culture and sensitivity. And then you start the treatment, and you allow your lab to work on it, because it will take them some time to come back to you, identifying what is the microorganism. So you want, of course, depending again on what are we dealing with, it could be blood, could be urine specimens, but anytime you have a patient that's admitted and you're suspecting any um, sepsis or UTI or whatever it is that you're suspecting, you want to collect that particular specimens. And then also, with moving in the same light, you want to also consider um, the site of the infection. So you can narrow down these antibiotic based on the site of the infection. So, this could be likely in the urinary tract, it would be E. coli, likely. Maybe not, but this is how you kind of start targeting them, and that's what physicians will do. And then once they get confirmation and get more specific information, they will change it. Leonard, is that how we spell never? Leonard's now checking back. Is never properly spelled? So when we start looking into the next category of the treatment, is your pathogen directed therapy. So now we are getting a little bit more narrow and more specific in about what are we going to see with regards to the treatment. So now you know what you're dealing with, right? Like, so you got your either a confirmation from the PCR test or culture or serology, and now you know this is a particular microorganism. One of the things to keep in mind with these cultures, some of them take forever, and if you ever waited for TB, it can be up to 6 weeks. Sometimes it takes 6 to 8 weeks, but depending on the lab. And so you'll see that labs have moved away from doing culture alone. So we'll see a lot of labs will do your PCR test, and they always will follow with culture, of course, but your PCR test will tell you right away within a couple hours, usually like a 12 to 24-hour turnaround time, depends on the lab. But the test itself is about 6 hours, so you can get really quickly a response to what are you dealing with in terms of the microorganism, and then that helps significantly reducing the use of wrong or not the right antibiotics, I would say. So that's usually how that works. And then you, as I said, whenever you send your PCR, you will always find that they're sending the culture as well. But that's just, and then for your PCR, you guys know, like, this is any test that we've seen so far, it's moving in that direction. So most commonly you'll find them for TB, gonorrhea, chlamydia. Of course, we see with with COVID, that's quite a prevalent test nowadays. So everyone knows about PCR. Do you guys want to take a 5-minute break, a bio break? Okay. Yes. So PCR and NAT is the same thing. So if you think about the PCR test or your NAT, what that is, it's the I was actually trying to learn a little bit more in detail about it. So they find this minuscule amount of the microorganisms, RNA or DNA, and they replicate it. So it's kind of like a photocopy machine, really what it is. So as soon as the moment it finds it, it's able to amplify. So it's an amplification method actually, and then it just replicates to a point where it actually can become readable for the machine. So this is where we ran into these issues where people were saying that we get false positives, and from what I understand, you actually can't get a false positive from these results, because in order to test positive, there must be something for it to replicate and recreate. I think it's the same methodology. There may be some minute differences between the tests, but in essence, they're the same test. So Ganda, when you say they were pooling, what does that exactly mean? Like they were pulling the specimens together? Because how do you know which one came from whom? What was the end goal or hope to find after they were pulling the tests? We had two different weather conditions since I started the class. We had rain and wind, and now it's sunny again. So hope no twisters, because that's not a good thing. Yeah, so that doesn't really, that wouldn't lead you to uh, accurate result. So how would you know? Um, it's a risk of contaminating your own samples. I can ask that as well. Let me write that down. I will put that question to my lab colleagues. I'm not sure what the pooling, how that actually works. And how can we with certainty say that we are getting, yeah, because you would be diluting that. Even so, even if you put, say, one positive with 3 negatives, you would be diluting that specimen, right? But I don't know. I mean, and then also, how do you know that you did not contaminate? So would you, if you're doing a PCR test where you're amplifying, so if that one had a positive, then all 4 would be positive? I don't know. I will have to ask. Yeah, that's what I'm thinking. You would not have enough to produce a high quality test. Hmm. I can't see that this is done by our PHO lab, just because of the high requirements for them. But as I said, I will follow up, and I'll try to find you answers for this and get back to you. So I think what it is, when I'm reading this, as much as, like, I'm not an expert in this by no stretch, but I'm thinking when they say pooling, they're probably using a less reagents to get to the result, and they're probably not actually putting swabs together. I think they're probably using less reagents and less materials to get to the end result. But I think from the quality perspective, that would be something that would be concerning. Yeah. Yeah. So what else did I want to tell you guys? Oh yeah, so I'm not gonna be here tomorrow and Sunday. So I'm actually gonna have a live tomorrow and Sunday. I will try to break away from my feral behaviors and actually try to socialize in a safe fashion. So I'm going out. Who is out in St. Catherine? Somebody from you guys is out in St. Catherine. So I'll be in your neighborhood. Yes, I'm going wine tasting. Fancy that. So yeah. So we're so excited. We have not been out. We haven't seen anyone else. So my husband and I are like let off the leash. So we've been outdoors on a patio on yesterday, and we went to a brewery too. It was so exciting. Yeah, if I drop dead, there's no classes anymore. I don't know. I'm fully vaccinated. I'm so careful, but I have not seen a creature outside of my husband and my work people. No, he's right. They are. They are doing anal swabs too. He's not lying to you. I do also promise sometimes my colleagues that this is how we're going to be testing them after they have potluck parties and all that. All right. I I was telling one of my friends, I think people in my class think I'm crazy. And she said, they think? I'm sure they know by now. All right. Someone actually wanted to get it? Oh my gosh. So did you try to offer them the entire series, like MRSA, VRE, CPE, and COVID? Yeah, that's one of the things, like when you are teaching new nurses, always make sure you bring up that you first do for the dual swabs, you first do the nasal and then rectal. No, but it's actually, yeah, it's a thing. It's not something that people are imagining. Yeah, it's a thing. There is a rectal. So the entire thing is actually revolving around the investigation around the viability of COVID once it passes through gastro system, right? So if you guys remember, we were talking about the spread, and in particular in China, there was some discussion around spread through the air vents in the bathrooms. So where people would be flushing the toilet on the floor below, and they were the ones that had COVID. So their neighbors on the floor above were testing positive shortly thereafter. And there was some suspicion that that could be from the air vents and aerosolizing from the toilet bowls after. And then thereafter, the investigation was even in York region and in Toronto, they were collecting sewer water on the streets, like the rainfall sewers, looking for if we are going to identify any of the COVID in there as well. There is other tests we can offer besides MP swab, but we have not started doing any of the anal swabs yet. Oh, for sure. Yeah, that's not really an issue at all, because we know it is something that will stay in the air. And if you have something that is as turbulent, and you have people that are sitting in a congested place and there is no air exchanges, you just have things that are blowing around, you would, of course, you will see that increase. But I think what with regards to the swabs and all this testing was looking more into validity and viability of the virus that's passed through the GI system. So we know that this is this is why we are talking about AGMPs and high flow oxygen in the patients as well, and management of the COVID positive patients in that are on high flow oxygen. So did any one of you guys attend any of the webinars that I sent to you? There is one that was about the vaccines, and the other one was I don't even know anymore. What was it? Okay, did you like it? Did you find it helpful, or was it just a bunch of mumbo jumbo that you didn't really find any benefit? Yeah, so the interchangeability, that was really good. It was interesting how they provided the answer without saying without saying no more AstraZeneca. They actually said it in a round way, right? So if you got your first AstraZeneca, you go and get yourself a Pfizer, Pfizer or Moderna. If you got the Pfizer or Moderna, you go and get your second dose Pfizer or Moderna. But they didn't say if you got AstraZeneca, go and get AstraZeneca second time. No, no, no. Yeah, so you can either get a Pfizer or Moderna the second dose. They're pretty much the same principle behind. They're just targeting a different protein. So it's interesting. I don't know if you had a chance to see that statistics where they actually showed that people who had a first dose of AstraZeneca and then the second dose of Pfizer, their immune response is actually the best. Again, it's the small studies that they're using as a reference. There is very, very small studies that are in circulation. So I'm sure with the time progressing and we will learn and have more evidence in our hands. But right now, there is only so many studies with so many participants. All right, let's move along.
Sorry, I just wanted to say, Cornelia, like mixing of the vaccines is actually not recommended. The reason I know this is because I recently just did all these vaccine hesitancy questions to go to long-term care homes. They don't recommend it. They say that you should get the same one that you did, except for AstraZeneca. If you got AstraZeneca, you can get either Moderna or Pfizer.
Exactly.
But
So
if you
they're
got,
saying if you should stick with your either Pfizer to Pfizer or
yes,
Moderna to Moderna. And
exactly,
if you got AstraZeneca, get either Pfizer or Moderna. And so
exactly.
their primary choice is to match, and then they're not advising against interchangeability. They're talking that it is safe. They're providing information that you still are getting a good response. But
They're
the
basically saying
primary
if the supply isn't there, then you can interchange Moderna and Pfizer because they're both
That's right.
mRNA. But
Yep.
they advise that you take the same one that you got before. You don't want to
Except
interchange
AstraZeneca.
because there's actually, yeah, except for AstraZeneca. Except yeah, so I've been working with some nurse practitioners and they've seen people that got Moderna and they got a rash, for instance, and they wanted to get Pfizer instead. But that's not how it works. Like if you just got the same Moderna, you would be completely fine because they were thinking that they had like some kind of reaction to it and they don't want to get Moderna again. But
Yeah.
no, you if you switch it, they actually had more problems. And this was all a study that was done by a nurse practitioner on my team.
Yeah. So, it could be, I don't know. I haven't seen anything with regards to rashes. I haven't seen any of those. But as I said, the recommendation still remains the same. Stick with your original. That's the number one recommendation. And then the next one is except if you got AstraZeneca, don't get the second dose of AstraZeneca. So, and then the third option is exactly like you said. If they don't have, when you get invited back, then take whatever. But yeah, I had a reaction. I had after the first dose, I got fever 24 hours after and a little bit of a headache. It wasn't so bad. The second dose, I was 3 days in bed. I was out of
Cornelia,
service
everyone's
completely.
different, right? Like all bodies are different. So when I got my first, when I got Pfizer, I got nothing, literally just a sore arm. And then the second time that I got it, I also just had a sore arm. But my brother
Exactly, and it's not
also got
a
Pfizer.
reference that it doesn't.
Yeah,
It's
everybody's
not
so
some.
different.
Everybody will have a different reaction or no reaction at all. But it's just I think it's important that we are aware and we share that information that that is a possible side effect. And the bottom line is this is your body working and this is what you actually want. And I think that's where people get a little bit worried that they're expecting absolutely no reaction. But if you think about all the childhood immunizations, all these kids do get some sort of reaction to it. They either get fever, they get cranky, they don't know to tell you what it is, but they often have a little bit of elevated temp, and they get a little bit of headaches and what have you. But that's normal. That's what you would expect from your body to respond in that fashion when it's working. Your immune system is working. Yeah, the mRNA material, the mRNA vaccines it's the same technologies. Everything is same behind it. Yeah, you're right. The stabilizers are different, but it's just like they all have their own recipes that we go about, but the technology is the same between the mRNA, and this is quite a new thing, and I think a lot of vaccines will be reworked in this to match this, because it's quite amazing. It's the nanotechnology that carries the messenger, and it's really cool to see how far and how things are developing in that world. There is a lot of hope for everything else after this vaccine, I think.
I don't know. It seems confusing. Like when you look at other people, it's either they had an immune response and you're like, okay, wonderful. That means their immune system works great because they're working against it. But then devil's advocate, the people that didn't end up getting a response to the vaccine, like, oh, maybe theirs is really better because they didn't actually have any issues. Like you literally don't even know. Everything is so
You
new.
don't know how to
You don't know which
respond
one's
to
good.
that, right? Like, oh well, no, you just power it through. It didn't even notice it happening.
So, yeah, so I'm like, who has the actual better immune response, me or my mom? Like my mom is sick and she's like dizzy and has headaches and all this stuff, and I'm sitting there going like, I'm completely fine. I'm like, okay, well, I don't know. Does that mean her immune system works better than my immune system, or is mine working better than hers? I
Your
can't really
mom's, of course.
tell. Yeah.
So just to get back to these questions here. So I think first of all, Marina, I think you have to find out Milo the cat who likes fancy water, and read and watch the videos of Milo the cat who likes fancy water. So you will find a little bit about the tap water and bottled water. It's just a joke there, but I enjoy watching this cat that picks always the most expensive water somehow. Um, and then also with regards to um, boosters, I do believe we will have to get additional vaccines. I don't think COVID is going away. I think it's going to become a thing for us. It's just going to be like flu circulating in the community. I don't think it's going to go away. And then also um, people are running the test to see how long does immunity stay, how long would we be protected from the first and second dose. So I think eventually we will be receiving either a booster or something to address the variants, because with the Delta, you see there is an outbreak in Ottawa, and there is also outbreak at UHN among the immunized population, and it's with Delta virus. So I think there is going to be something in the works for us with regards to these variants that are coming through. I don't know. I feel like, I'm just kind of looking what's happening, and I'm thinking the moment they come up with a new targeted for the targeting these variants, I'm signing up. I'm gonna be the guinea pig. We want that herd immunity. So in my household, we are 75% immunized, and I don't really feel so confident still, like going out. And even when I meet with people that I know they're 100% immunized, I'm still very, very cautious. But anyway, let's move along to our class here. We can talk about COVID and vaccines until we are blue in face, obviously. So the factors that do affect our outcomes when we are talking about the antimicrobial treatment and therapy, it's important that we start early, prompt treatments, of course. And then also looking into what are we dealing with regards to the microorganism. So how virulent are they, and how susceptible are these microorganisms. We also will be looking into the activity at the particular site. So you want to target, again, the same sites as we mentioned earlier. And then also one of the big factors that does affect the treatment is the patient itself, right? So how are they coping with the treatment? I mentioned to you guys before that I had patients who couldn't go through the treatment to address the infections because their bodies couldn't take anymore the antibiotics, and they just have sadly succumbed to, like, infections as simple as pneumonia, or something that people normally shouldn't be dying from, but because we have no means of fighting it off, and it's just overtaking the organism, so they have to stop treatment and rather do nothing than actually cause more damage. And then, of course, when you're looking into the body sites, I already mentioned to you, this is the certain body sites are more challenging to treat. So this is why we get concerned when you see that your patients have meningitis or infections that do affect the heart valves, because those are challenging to treat just by the location. So it's the medication can't penetrate, or the actual sites are difficult. So yeah, I think it's going to be similar to maybe not annually for COVID, but I think maybe something like every 2 years, or maybe we will be sent to do the teeter tests and things like that. I don't know, but I think that's just my opinion. I'm not pulling this out of any scientific background. This is just how I feel about this. So take it with a grain of salt. All right, so factors that do affect the outcomes are, of course, not only the choice of the antimicrobials rather, but the dosage. As we mentioned, there must be enough antibiotic in the body to ensure the steady level at all the times that will actually have effect on your microorganism. So when you look at some of these doses will start high to kill the microorganism, but they have to be low enough to not cause damage to the host, to the humans, of course. So sometimes you will find that they need to be adjusted. So we spoke about your vancomycin, tetracyclines, all these that they are so they can cause damage to certain organisms or systems. So you will see that, as I mentioned before, you will find your physicians will order these tests to determine the levels, and then they will say whether to continue or just bring down the dosage or replace it for something else. Depends on what you find. So with some of these you will find, and I would say probably most common you will find that is affecting liver, of course, because everything is going through our liver to get um, cleared and cleaned. But also you will find some of them will affect your kidneys, and you will find that in some cases, of course, you will also affect your GI system as well. So, when you guys tell me our patients have diarrhea. So that may not necessarily be the same level of the toxicity, but you will find some people will react to these broad spectrum antibiotics and have diarrheas as well. So to curb that and actually control what is happening and have a better understanding, I mentioned to you before in previous lectures as well, as these antibiograms, and they're produced by your labs. Your lab, whoever is wherever you're sending your specimens, they have it. Also, you can download them just on a regional level. I have been finding them from the public health. What is the other one that I have been accessing? Goodness gracious, I can't think of the name of the lab. Life Labs. So Life Labs has broken down by province, and you can use them to see how does this actually look in terms of the regions, because not all the regions will also have the same response. So you will find that sometimes you will find a difference between region to region how certain either antibiotics are used or the resistance is forming in certain regions. So you may be in, say, for example, Toronto, have one of these antibiograms produced for GTA, others for Niagara region. So there may be difference. So always take a look at how they're actually different. You will find also that there are certain microorganisms that are more prevalent with regards to resistance. So you can also look at the maps across Canada, across Ontario. They're broken down and actually showing you where it's really more resistant, say in ESBL, what is more CPE, what regions are affected. And usually has to do with also the immigration, so where people are coming from. And then also you will find pockets like in New York where there is a lot of CPE in New York, and it's because a lot of people actually go back to Israel there. So it's just kind of looking at where people are coming from. And I have been asked in the past by one of my patients if I'm racially profiling, which kind of got me really stunned. I never really thought of that. So just something to be aware that you may be asked as well. So it never really occurred to me that this is how people also see what we are doing. Are we racially profiling our patients based on where they're coming from? Had absolutely no intention to do so, of course. So as I said, your antibiograms, you can ask your lab to either send them. They're usually also available electronically, or you can just access them from the websites. And again, as is IPAC, we really don't use them so much. They're kind of neat little tool to have and see what kind of microorganisms are building up on resistance. And that's where you may kind of ramp up in your long-term goals for your healthcare facilities if you're seeing certain increase in certain organisms and prevalence. So you want to curb maybe that, so you can use these antibiograms for prediction and focusing and working with your pharmacists and your infectious diseases physicians. But it's something that, as I said, we really don't use this on day-to-day work because we are not the ones prescribing any of this medication. They're usually created and published on annual basis, but you may ask if there is something of a concern, if you have um, any outbreak that's going on in your facility and it's particularly rampant and you can't get rid of, you may get one of those off regular schedule done for you. It's something I have never done it. I've never been involved that much, but I know in facilities that have Pseudomonas in particular, where they're fighting some of these really aggressive resistant organisms that have a tendency to um, be often related to the VAPs. Yeah. You will find the Pseudomonas that's multi-drug resistant is really, really hard to kill. There is a hospital in the state that was newly built hospital, and they had a burn wing. So they had entire population of patients that had skin, no skin almost, or damaged skin. And Pseudomonas is a water-loving organism. So when you have something like an open wound, of course they would be at risk. So here's a question for you. If I had an outbreak of Pseudomonas on my floor, what should I be focusing on to reduce the risk of spread of Pseudomonas? Where could this thing be growing? I'm going to leave you to sinks. Yeah, sinks could be something, something more common actually that you will find. So think about times that before COVID, and we had more visitors, but people bring into the hospital quite frequently to our patients. Flowers. So it's a water-loving organism. Think about that. So it would be, of course, the water in the flower vases. So we don't like that for sure. So other things would be your hydrotherapy tubs. Those are also a big, big growing grounds for Pseudomonas. Of course, the ventilators, but outside of those, like medical devices. So it has to be something that actually does have a water in, because the it really thrives in water, in dirty water, in water that has a lot of this organic matter in it. So anything like hydro tubs or any not so much soil. Soil is more for us concerned from the dust perspective, but your cut flowers and vases. Changing the circuits and changing the replacing the water in your VAPs, in your ventilators rather. Yeah. Think about dirty grows water, what it grows in couple of hours. And if you have an outbreak going on with Pseudomonas, something definitely to look at. Oh, that sounds painful. So anyway, let's move along with our antibiotic resistant organisms in our session. So with sinks, I would mostly think CPE, because again, yes, there is a risk, of course, with that, and also something that would be splashing as well back at you. So really anything that will hold the water, think about anything that will hold the water, that would be it. If they're lingering around, then I would say yes, I'd be concerned with your towels as well. But hopefully you don't keep them around for a long time, or not really touching patients, or of course. So here is your a little bit of a graph from that I just thought would be interesting for you to see. It's interesting to see how the antimicrobial resistance actually affects the economy as well, and not just the what we like to talk about is the healthcare associated infections, but look at the number of lives that actually have um, been projected to be lost by 2050 in Canada. Is we are anticipating to lose 396,000 lives. Um, and that would be significant increase for us from 26% to 40% only if they're looking at no change in antimicrobial resistance treatment and reduction of that. So it's kind of interesting to take a look at. So in 2018, you will see that we have lost about 5,400 lives due to antimicrobial resistance in Canada. And then they're anticipating, if there is no further work done, so we stay where we are right now, that we can expect that to go to on annual basis to 13,700 rather. Okay, so what it is, like, of course, you guys know it is affecting everybody around the globe. It's some countries can't afford the additional resources, and then it falls down to countries that are more resourceful to actually take a leadership and support. So morbidity and mortality are also increasing, of course, through the use of through the increase of the antimicrobial resistance, as you know, and then also the cost. You can see that how much money it's expected. So right now, Canadians are spending about $2 billion on annual basis to treat antibiotic resistant organisms, and the anticipation, again, if we stay where we are, we don't change anything, would be about $21 billion spent. It's a lot of billion dollars. So I think we shared this one before. So this is your Kirby-Bauer test. You will find this. That's how they run the susceptibility. They put a little bit of the paper that is infused with a certain antibiotic, and then they're looking into the circles around and whether the antibiotic is actually managing to kill the microorganisms around or not. So that's how that looks in kind of graphical sense. And this is how this looks. This will be your ELISA test, where you're having these little wells and they're putting in antibiotics, and then they're bringing in the actual broth, I guess, that is to be introduced, and see how whether we are getting a response or not there. So that's kind of just kind of cool to see. Yeah, I think, Leonard, it's COVID is something that has changed a lot of people's social life and has a lot of negative outcomes with regards to the psychology and mental health. And a lot of people lost their jobs, and so all of this does not help. So the mechanisms of the antimicrobial resistance, you guys know, it's drug inactivation or affecting the target sites. So that would be your MRSA, the ones that kind of have ability to push out the antibiotic out of their own cells. That will be your efflux. So that's your Pseudomonas and all your organisms that are actually producing carbapenem. And then you have also your metabolic pathways, the ones that know how to bypass the and avoid the entrance of the antibiotics. So it's kind of different methodology how they function. So this is, again, just a little bit of a visual to see how that actually looks in some, if you can, if this is a better way for you to kind of understand the terminology. It's the same, exactly the same message from before. It's just a visualized here, and then you can see which organisms are responding to what drug and how, like what mechanisms are actually to responding to a certain drug. So you can see that your cell walls are the beta lactams are going through the cell walls, and then you have your inactivating enzymes as well. So you're looking at the on the left side, you're looking into the target. So what is the antibiotic supposed to affect? And then on the other side, on the red, you will see how does this actually learn to fight it off. So what's important again is, I mentioned at the beginning, is it is something that is uh, naturally occurring, but also you will find that over time and over use and misuse of antibiotic, that some of these microorganisms have actually learned how to fight it off better. So well, we are finding ourselves in this kind of uphill battle against these microorganisms. So here is just some of your examples. I don't think anyone will be asking you when did MRSA get first time documented as antibiotic resistant or anything. It's just a little bit to see how this actually has happened over the time. So there is your hospital in Maryland that is kind of highlight there. I don't think anyone's going to ask you that either, but it's the first one that we saw is when we had out of 11 patients, sorry, out of 18 patients, 11 died. And then how do we fight this? Of course, we create our own programs to develop approach to manage the use of antibiotics, and it's quite common in the acute care settings. I mentioned this before as well. And then you will find that over the time these hospitals are providing support to the long-term care facilities just because there is no capacity in long-term care facilities to have their own antimicrobial stewardship programs and leadership in there. So there's some of those resources that you can tap into. So again, what more looking into what is the, I guess, the components, how do you build your stewardship around, is thinking more about the having proper access to the treatment, but also being accountable to the patient in terms of doing no harm. So we want to make sure our patients do have access to the treatment as well. However, while we are not encouraging the further development of resistance. So if you are a part of building a team, or if you're asked to develop and design the program itself, it's never going to be on your own. You have to have support from your senior leadership. The thing that is really good about this for the acute care settings is that it's a part of accreditation. And the government of Canada is actually mandating acute care facilities to have fully functioning programs in place, which has not translated into long-term care facilities yet. But I'm sure at some point you will be also asked to collaborate with acute care settings to develop these programs or piggyback on their programs. So you will have, of course, to have support from your leadership. You will have to have somebody who is an expert in understanding the drug. So usually that would be your pharmacist and your physicians working together. But also, how are you putting this program in action would be something that you as ICP may be involved more once you start designing these programs. You want to make sure that you have a good system to track use, and that again falls into pharmacy more than anything else. And then reporting, usually it's done by the pharmacy and the ID doc. So any report I have seen coming through, and any verbal reporting, anything was always coming from our ID docs. And the same thing, education again is more from the pharmacist and the ID docs to the physician population. So there are some CDC stats. It's just something I wanted to share with you. It's kind of help you more from the visual perspective. I know it's a lot of dry information with this particular lecture, but what is really important for us to know is that it is global. So for us, it could be something today we don't have it in our house, and tomorrow you may have a resident or a patient that came, traveled from somewhere else, and brought something we never saw, and that puts the rest of the population at risk. It is increased, of course, with traveling, and also dependent on the country's internal policies. So you will find that this is interesting stat there that they have that in India, 58,000 babies died last year due to antimicrobial resistance. That's a lot of babies to die as a result of antimicrobial resistance. So and in Thailand, they also have about 38,000 deaths, but that's not just in the children population. So this is across. I mean, it's obviously not comparing apples to apples here, but it's just an interesting stat to see. And where is this actually coming from? When we start analyzing the way we work and the way we participate, not just from the healthcare system, where is this also coming from and where are the risks? So you will see again, the hand hygiene is one of the big problems, which I think poor Semmelweis must be just turning in his grave after everything said and done. We are still fighting with the hand hygiene, but it's also the animal husbandry has a big role in it. And you will find that in Canada, we do have very strict rules for our own farmers. However, the rules are not the same for food that's being imported from the other countries. So, for example, a good example for you would be the lamb that we are importing from New Zealand. It's such a tight rule on that one. So our Ministry of Agriculture actually has office in New Zealand that oversees the manufacturing of lamb in New Zealand, because we are importing so much lamb from there. And to prevent anything from being imported unwanted, they actually have established Canadian office there where the food is being grown and slaughtered for Canadian markets. So something to know, so that we do collaborate with some of these manufacturers, but obviously we are looking again at the countries that are comfortable and have their own standards high, and they're comfortable with having somebody from other country coming in and setting house and setting office there to oversee the manufacturing. It's not everywhere like that. So something just kind of there is a trivia for you that you will never need to use, but just here is information. So, as I said, it's not new. We have addressed this multiple times before, and I think it's important that we don't think about this as we are just finding out information and we are just dealing with this right now. It's been around for a very, very long time. You know that we had information about the penicillin resistance even before penicillin actually hit the market. So it's not something that is new, but it's spreading and it's affecting the outcomes and livelihood of everybody in the world. And also there is no new antibiotics being developed, so it's just not keeping up with the manufacturing of antibiotics, how fast the microorganisms are catching up. So I thought this was kind of eerie, and very futuristic from Fleming to actually put this out as a statement where he actually said the public will demand a drug, thinking about the penicillin, and the drug will begin a new era of abuses, and the microbes are educated to resist penicillin, and host of penicillin fast organism is bred out, which can be passed to the other individuals and perhaps from there to others until they reach someone who gets a septicemia or pneumonia, which penicillin cannot save. In such case, the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who finally succumbs to infection with penicillin-resistant organism. And I hope the evil can be averted. So that was his projection to where we will be. And it is really, really concerning that we did not really take that seriously and did not act before we find ourselves in a conundrum that we are now. But there's always hope. We're moving in the right direction, I would say. So the need for stewardship, there is different drivers coming at us. So there would be the World Health Organization, CDC. In Canada, there is also the drivers that are making us act. So as I said, for the acute care settings, there is the expectation to have established the fully functioning stewardship program. But here's some of the stats for you to take a look. The CDC estimates that over 2 million illnesses and 23,000 deaths occur annually. And this is just an estimation. Always think about any of these stats that they're only a tip of the iceberg. And the reason for it is a lot of things do go underdiagnosed and a lot of things cannot be clearly assigned to a particular cause. So you will find on your, if you ever review your patient's death certificate and you're investigating any of the cases that are part of multi-drug resistant infections or C. diff infections, you will find, take a look at those death certificates and what are the causes of that. So this is something for you to do when you go back to work, if you have access to that. Take a look and you will see that it's rarely it's listed as a number one cause of that. Most commonly will be either failure to for heart or heart attack or this or that, and then in rare occasions you will find that is listed as one of the causes. It could be even just sometimes in the notes, and if it's even mentioned in the note, we are lucky. And it's just something that physicians have to get around to include, that a patient actually has tested positive or that we treated them for the multi-drug resistant or antibiotic resistant organisms. But here it is. In Canada in 2018, it's not that long ago, we had about 980 bacterial infections. Out of those, 250,000 were resistant. So that's quite a lot. And then if you're looking at the number of people who died from these infections, it's 14,000 deaths. And again, as I said, this is just the tip of the iceberg. We are not seeing clearly these numbers, and I don't know if there is a better way. I'm sure eventually we will have better ways to capture everything that is happening. But right now, those are all estimations that we probably are looking at the highest numbers. So when you look at in terms of the preventative piece, yeah, it's a lot. So it is 4 in 10 cases that could be saved. So if you're looking in our class we have 40 students. So how many of them would actually die from, or of us would die from these preventable diseases? So there is a quick, easy calculation for you guys. I think Sharon is an expert on this now. She sent me some crazy gonorrhea assignment. So again, as I said, if we are looking into status quo, not changing and moving in improving in antimicrobial stewardship, the estimation is that our resistance will grow by 40% in Canada. So you would be looking at a significant increase of that, of course. So we would be looking at potentially seeing about 396,000 deaths on an annual basis in 2050. So that's a lot. Okay. Okay, I will not be picking on you, Sharon. So when you start looking into the way they function, the antimicrobial stewardship, what are they focusing on? They already are dealing with choices of the antibiotics, and the physicians get involved. So there's different ways around that involvement, from the ID docs and having conversations with the primary physicians. Pharmacists too, you will find them often having conversations and recommending a different drug to the physicians in terms of the antimicrobial stewardship as well, but also looking into better outcomes for the patients as well. Dosage and duration play a significant role as well. So it's important, when you go home after visiting your uh, family physician and they give you drugs, it's important that you finish that course of treatment. Even though you're improving, you want to go through finalizing the treatment. If you're not improving, it's important that you go back and say, listen, this is not working. Here is the drugs you gave me. So you give them back to the pharmacy, they discard them in a proper way. You don't want that to go into landfill either. So, or down into drain or a toilet. So you want to give this back, and you don't want to self treat in future with that either. But it's important that you go back and ask them to give you another antibiotic if you're not responding in first 48 to 72 hours. The
Cornelia,
big
that has happened to me so many times that when I was younger, they didn't take my tonsils out, and I ended up getting so many different antibiotics that a lot of them don't work on me. So I'll take them for 7, like it'll start feeling like it works, but then it won't work. Then I have to switch it with something else, and then I have to switch it for something else. Like, so for 3 weeks, I will literally be sick because
yeah.
none of the actual antibiotics are working with me. And then I finally got my tonsils out, but in
So
my 20s.
it's also, selection, and what are they selecting? And it's not necessarily that is it's you, it's also the knowledge base of the physicians, and what are, so they will try with most commonly prescribed before they go to something stronger as well, because they don't want you to be also dealing with these toxic side effects of some of these other antibiotics that you may get. So as I mentioned before, less antibiotics are manufactured, and the simple reason for it is there's no money in it. It's no money in manufacturing antibiotics. Better investment for pharmaceutical industry to develop Viagra's of this world than actually antibiotics. And that may sound awful and sad, but that's simply what it is. It's all about money. Every time you put on a scale um, money and anything else on the other side, money always wins. So that's as simple as that comes. And we don't have much time to deal with this, so it's really interesting. um, Sharon, do share with us. I'm sure it was more expensive to develop that than antibiotic, but good to know.
Sorry, what is the DST? I don't even know what that is.
So Sharon is telling us, it's so you always want to run first of all, you want to run a test. Like if you're treating somebody with antibiotics, so for example, your particular case, you want to collect a swab, right? So, and this is what Sharon is telling you about. So you want to make sure you're running that susceptibility test. So let me see if I can pull that up. Okay, see, where is this? A couple of slides back. It's 35. So it would be something like this. You would use that swab and then see what particular drug would be responding the best. So it does take time. It's a lot of work for them, especially in a community setting. They really don't have drive to deal with this, and usually you would get this more done in, of course, in acute care settings um, versus community settings. So this is why they don't really do this for us. Where am I? 47, I think I was. Yeah. Okay. So when it comes to use of antibiotics, I think it's critical we recognize that safety perspective and safety piece that we have to take in consideration. So we discuss this. It is quite a lot of patients that will end up with some adverse effects, and they're saying it's about like just close to 20% of hospitalized patients end up with some sort of adverse effect after use of antibiotics. They do include death as well, but most often you will end up with allergic reactions or cross sensitivity between different drugs, so interactions. So it's important that you also share when you're at the doctor's office to let them know if you're using any of the other drugs, because it can interact as well. Usually in the hospital they have a little bit better handle on situations where you have a patient that presents, and they have ability and ways to find out what drugs you're on. But in community settings, it is your responsibility to take care of that. And that's another big component for the antimicrobial um, resistance, is actually community settings. So of course, you guys know the C. diff is another one that is a big deal for us. And I know so many times I would come across that our ID docs would just say to discontinue use of some of these broad spectrum antibiotics because it does cause C. diff. What is really interesting, one of the actual medication that is used to treat C. diff, it's also one of these leading causes for C. diff. It's your metro. In another thing that I actually have not didn't know much about is the alterations that do affect. So when you have the microbiome and alterations of microbiomes, how does that affect the autoimmune syndrome in pediatric population? And that was new to me when I was researching this particular topic for your studies. That was news to me. I did not know much about it. I don't know much about the pediatric population, but that was interesting to see how it does affect the autoimmune systems with the children population, the use of antibiotics. So interesting to know. So some people will talk about like food sensitivities and things like that in relation to some of these autoimmune syndromes. And of course, use of antibiotics during pregnancies has also, so they usually will ask us females if we are pregnant when they're prescribing some of these antibiotics. And then if you get some of them that are at risk, you will find they have actually a pregnant woman imprinted on the pill, and it's crossed out. So something to keep your eye on when they come through. As I mentioned, common adverse effects rather, is allergic reactions. You will find quite commonly people will have a rash or They may end up like a gastro symptoms. We discussed that, but in extreme cases, you will have organ failures and like your kidneys and so on and so forth. It's interesting stat that I found is that about 140,000 people actually end up in emergency departments as a result of adverse effects of antimicrobial treatments. So it's interesting to know. And of course, the everything comes back to the antimicrobial stewardship as one of these um, preventative measures that can alleviate pressures at the ER. So if you're having so many visits and we are able to control and manage, that would reduce the visits to ER. So that's one of the selling points. Yeah, so and that's fine. So it is it's not unheard of that that physicians will actually withhold. And I know I hear quite frequently young moms complaining the baby has an ear infection, doctor doesn't want to prescribe any antibiotics, and that's quite common. They will not until they are really found themselves in a situation that is a must, and they will also run the actual sensitivity test before they do that. So something to be aware as well.
Honestly, Cornelia, that's very irritating that you can't
Be-
get antibiotics at all. Like, I understand the whole resistance piece, but if you're a full-time mom that has to go to work and your kid is not feeling good and they're just getting worse and worse and worse, and you show them to the doctor and they're basically like, well, unless they have more of this, then we can't do anything. Where are you
yeah,
supposed to leave your kid? Like, where your kid's gonna go to daycare during COVID?
yeah. No, and like I understand what you're saying, but in a long run, it is better for your kid not to get it. So, it's hard to balance the life, and there is no doubt about that. I had somebody ask me from back home where we are a little bit different society. I'm from Serbia, if I didn't mention this, but much closer networks. Even if you don't have close relatives, you have a lot of friends that are ready to help and take a look and look after your baby when you're working and take
Well,
them. So it's really hard
I've actually
here.
been born and brought up here, but I don't trust anybody because everybody's been going out. They have their
No,
own family members
absolutely.
that they're with.
I
So
think
it's just
it's
COVID
just a
kind of did a different
different
thing.
it's
Yeah,
a
COVID drove
different
a different.
setup, right? It's
Yeah.
completely different culturally. So I know when we are talking between different, as I said, I talk to my friends back home, and they just can't comprehend that, what do you do when your kid is sick and you have to go to work? And we are not getting as many sick days here in Canada like they do in Europe. We don't get a lot of flexibility for parents that are working. There is not. So I think we should be looking into more of that work-life balance than actually slapping antibiotics on everything too as a ticket out, right? So I think we have a different type of problem here. And I hear what you're saying, but I don't think that's a solution. I think we have different type of issues to address through more of that social aspects of
Yes,
our living
definitely. I
style.
agree. Like, I don't think antibiotics are the solution. The problem is that if you're able to get the time off, then it's fine. But if you're not able to get the time off because it counts like the 3 days or whatever
Of
that they
course.
have that you need to give like a note for, that
Yeah.
is the issue. The issue is not staying home and like
Yeah.
not getting that pay. The issue is, where do I go because now I'm on penalty.
And then you get sick after that, right? So
Exactly.
then
And,
and
and then
then and then
too, you get sick for another 1 week. It's
yeah, and
hard.
then they put you then on performance evaluation because you're
And I
sick
never
all the time.
realized any of this until I became a mom.
Yeah,
Until I went off mat leave and I went back to work and I watched her
it's
get sick. Like, I didn't realize any of this. And I was like, oh
it's
wow.
impossible. I find we are not very accommodating to our colleagues, and again, in comparison to the States, I think we are golden. However, when you look at some of the, even New Zealand and Australia or European countries where there is more flexibility to support families and support moms that work, that's quite we still have long ways to go, right? But that's a topic for some other time. So what brings us to the predicament that we are facing? It's decades, of course, of overuse. And when moms like Jack come and say, or Sharon, I have a problem here with my child, I can't. Or I'm sure Marina was, before she sent her kid to university, having same problems balancing the life. So the doctor would just give you antibiotics, say, here, have an antibiotic. I don't want to hear about you anymore. So this may be a solution that didn't really work out for anyone, came back to bite us. But joking aside, it has been an issue and something for us to deal now with, and to look into finding solutions. So the it has to be implemented across the facility, and it has to be integrated into all your programs. So it's not a program that lives on its own. So when you look into your antimicrobial stewardship, you usually have a very small team behind it, and it's not a lot of people that are involved, but in successful programs, that it becomes everybody's responsibility to look into that. And you find that with the programs that are very successful, you have support from the senior leadership, you have very vocal pharmacists, very vocal infectious diseases physician who is willing to support their colleagues through this implementation and maintenance. So once you implement the program is one thing, but how do you make sure you keep it fresh and keep it going and keep everyone keep it the best functioning, I would say.
Yeah, personally, I don't believe in antibiotics. I don't give that to my grandkids. I try conventional medicine first before I take them to the doctor and said they need antibiotics. And their doctors don't really hand out antibiotics like that either.
Not anymore. I think things have changed, and it's not any more prevalent in Canadian healthcare. However, I will also say that you step into another country, you can buy antibiotics over the counter. I know people are buying them themselves and self-treating and taking them with when they have flu and whatnot. And I can't shake it out of some of my friends to stop doing that. It's just like this is their safety net, I would say. So setting up your goals and targets is critical when you are implementing the program and putting your program in place. So you want to make sure that um, you have a very clear goal, and you want to set it up in terms of long-term goals and short-term goals, and something that is achievable in a shorter term will propel your program. You want to have access to tests. So when you're setting your program, you want to ensure that your lab can support you through the only any tests you need to have done in a really quick turnaround. Because if you're waiting for that susceptibility test to come back, you're extending use of broad spectrum, but also you may be impacting the outcome of your patient as well. So this is in the States. I'm not sure that we have so well established support yet in our healthcare system, but it's important for your CIC exam that you at least know that there is support. There is trainings for the pharmacists that they can take the courses and become more of experts. So there is to support their homes where they're working. So this is not in regards to acute care settings. This is more with regards to long-term and retirement homes where a pharmacist would take over the role of a leader for creating, establishing, and driving the antimicrobial stewardship. So you as an ICP working in the States, you may be working without an ID doc or have somebody who would be providing services from your local health center or something like that. But which is, I think that's similar to what we have, but I'm not sure that we have this program supporting our pharmacists here in Canada. So when, again, I think this was also mentioned at the beginning, I just want to make sure we have this very clear because this may be on your CIC exam in terms of what are the core elements and what is important. So you always want to think about your leadership commitment being a number one element. You need their support. They will be the ones providing the budget and allocating staffing to drive this particular program. Of course, you want to have team members who are accountable. So usually these programs are driven and led by your ID doc. So that seems to work again because of the expertise and the reputation these ID docs do have in our healthcare settings. So you want to have, of course, the pharmacist as well, and then you will often have an IPAC person sitting there as well. And if you're not at this table, make sure you are participating or at least you're somehow involved because it does make a big difference for you. But also as these programs are going to be going through a major growth, you want to be a part of it as well. And I mentioned the implementation, use of a proper antibiotic, phasing out the antibiotics, discontinuing antibiotics. So all of that comes in the action. So some of these can be actually set as automated processes. So we'll see that sometimes they will have discontinuation of some of these treatments that are automatic. If the patient has met the criteria, they put a stop on the antibiotic uh, prescription, so to say, so they have a limit on them. The physicians are always looking at them. Your ID docs may be also setting up some sort of restrictive measures in terms of what drug gets prescribed, and if one of those that are broad spectrum drugs are being prescribed, they need to be approved. So they either have to go through approval with a pharmacist or the ID doc. And that's a lot of work, but that's one of the ways to control the prescriptions of these broad spectrum antibiotics. And of course, you always want to have your final reports or semi-annual reports that are going out and actually finding out how did we do, how do you measure your success, and did we show reduction of infection in with this antibiotic resistant organism, or did we implement a program and did we get now assigned to every each floor, say a pharmacist that is leading this particular unit or this particular program in the antimicrobial stewardship. So you can have different ways of improving and developing the program. So depending on the model that your facility decides on. And of course, as I said, education that tends to be mostly focused on the physician population than anyone else, just because of the the mechanism of how the antibiotics are prescribed. And always think about it is in terms of a team effort. So it can't be done without having people behind us. So I already spoken about your accountability and having access to those antibiograms. You can access them easily. They're not a problem accessing at all. You can just either call your pharmacy or, as I said, go on their website. So these actions is what I mentioned. The pre-authorization is when the clinician who orders the antibiotics would have a approval from the ID doc. Sometimes that's really challenging for either a pharmacist or an ID doc to field all these approvals because it's just you're inundated with it. And I think most common would be the one that they do complete a review. So they will come around and within 48 hours, 72 hours, they review the orders and make recommendations. And depending on, as I said, depending on what works for your facility, but I have mostly seen these that are kind of audit nature and follow up. So days of therapy is another thing that's a system in place that will have this keeping track of the days of use of antibiotics. So you will find this is important when you are reporting, creating reports to know what is the day of therapy and how many days of therapy has a certain antibiotic being prescribed. So usually you're looking at different dosages. So there is an example there for ceftriaxone, how it can be done, but you're always looking at this is one day and then it's 2 days, 3 days, and it has to be that's your 24 hours period, I would say. Then your length of therapy is when you are looking at the actual treatment. So how many days has some antibiotic being prescribed for? So it could be 7 days or 10 days and so on and so forth. So all of these you will have broken down in these reports that your either pharmacist or ID doc will be sharing. And then of course, so this defined daily dose, that's another one that is in use when you're reading about antimicrobial stewardship. That's quite a common term you will come across. I really don't see anyone actually asking you any questions with regards to the dosage. It's just being familiar with the terminology for your CIC course. I don't think anyone will be asking you to dive into great detail around this. So just be familiar with what they are. So length of therapy, day of therapy, and your defined daily dose. I have never been asked anything of any of these questions in any of my previous exams. So as I said, for the reporting piece, you want to go back to creating your program. So what did you set up as your outcomes and targets and goals? And now you're looking at what are these measures that you have collected. So what did you collect your process measures in terms of collecting data with regards to duration of therapy or compliance versus the outcomes. Outcomes would be looking into your readmissions, for example, is a big one. And that's one that actually hospitals do get penalized on, and so do physicians. So that's a big one for them. And it's kind of a fine balance between that antibiotic treatment, and if the patient does not complete the treatment and they return, so the hospitals do get penalized for readmissions. So there's something to be aware when you're discussing the programs and setting up these programs, because they do get so because the driving force, Sharon, behind it is they want to reduce the length of stay, right? So the more you have flow through the hospital, you're banking more money. However, although you want to reduce the length of stay in a hospital, at the same time you don't want the readmissions to be high. Yeah, so I think it's a financial penalty that is assigned, because the physicians they are they're not staff of the hospitals, right? So they are independent. They are practicing at the hospitals, so they're targeted differently than the hospitals. I don't really know much details around it. I just know that there are some penalties assigned through that, just because I'm listening to them talking, and I've been involved with some of these
Yes,
development of some of
Cornelia, they're paid differently. They're paid in a different way than we are. So they're
yeah, for
completely
sure.
yeah.
They're paid differently, but with regards to these the penalties that come with regards to readmission, I think they get like ticked by some percentage or something like that. So education, there is education that's available to you free of charge. I posted on our under our lecture. If you are interested, you can take that and become an expert on antimicrobial stewardship training. I don't know why would any one of us want to take a deep dive into this where we are right now. Maybe as you are getting more into the role and you're maybe developing a program or something like that. But at this point, I really don't know, can't see any purpose for myself, but I don't know, like would be nice one day in the future, but you know, things come in life. And there is obviously different institutions that support that. I would say APIC has a really good program that I've seen, and Shay. So again, with regards to IPAC, as I said, we get more into that, pushing the program and working with the development. So more of that kind of like brainiac piece on how do we develop this, how do we push this, what do we need to do from reporting perspective, how do we connect people that need to be connected to generate information from the lab, gather information from the lab. We can advocate for it when we are huddling on the units. We can support and connect our physicians with the right resources and just talk more about it, but we don't prescribe. We don't really have much of that actual active involvement from the actual prescription piece. And as I said, we do help our ID docs and pharmacists track information and collate information and report that. So I've been involved with some of that, not much, very limited exposure for me. I don't know if any of you guys had any of this exposure in the past or heard anything on your teams, but from me, I had a very limited exposure. And as I said, for most part, we talk about, you know, your MRSA and decolonization and CPE and preventing the creation of the environment to become a breeding ground for this. So more about like targeting a little bit of a from a different end than actually being involved with any of the elements of prescription or dosing or duration of the prescription. So we don't get too involved with that. So obviously I can't spell again. I think something is going on with my spelling. I think Leonard must be rubbing off on me or something. But as I said, in our long-term care facilities, there is limited access to these programs and very limited resources. So you may be the one, you may be it for them, and you may be the one actually that they ask you to find resources and way to support the antimicrobial stewardship as they come. So you may be the one reaching out to your infectious diseases physicians. I know all of them do support. I don't know, I've never worked with one infectious disease physician that did not support local long-term care facilities when asked. I've been involved with one of these ID docs in the past with regards to catheter-associated urinary tract infections in one of our sister homes. So we helped them start or stop treating the positive urines without the actual infection. So establishing the definition of catheter-associated infections, helping them understand what that actually means. So we provided resources, materials, and education, and then he was going in and reviewing the charts and treatments of these patients until they actually became so robust that they managed to well, I am dyslexic in so many ways. I can't, like, by the time I'm done presenting, I can't speak anymore. So I think I start off really bad and it's just a mess by the end I'm done. And I think it doesn't help that I use different languages, so it just becomes quite hectic in my head as well. So in Canada, what's really important for you guys to know is that we actually have also signed up for stop of treatment or use of antibiotics that is not for treatment of illness in the animal population. So we'll find that they will use, of course, if the animal is sick, but they don't use it anymore as in past was used, or in some other countries they're using antibiotics to increase the growth, improve the growth, and gain the weight for animals. So that's no longer in use. So there is entire that falls under the Codex Alimentarius, and Codex Alimentarius is actually a codex that speaks about food safety, and it's applied across the world. So Canadians also fall into that category as well. So for us to know is that majority of antibiotics is actually prescribed by general practitioners and dentists. So that's kind of interesting to know in community. So look at this, like 92% was dispensed through the pharmacies, and only 8% was actually prescribed and purchased by the hospitals. So Leonard, I never know, is it walkie-talkie or is it talkie-walkie? And like some of these things, I always say a sentence in like mumbled way, and I don't know how people actually end up understanding me. Sometimes I just listen to myself and think, what did I just say? That's not what I meant to say, and I have to sort my thoughts in my head. But you've been good. No one's been complaining, asking you, what are you talking about? Either you stop listening or it's just like whatever goes. So thank you. I needed that. So in Newfoundland and Labrador, it's actually interesting that this is our province that prescribes most of antibiotics. And considering the size and the population, I would say it's interesting to know that they actually prescribe double of the Quebec's amount of the double of amount than what Quebec prescribes. So Canada has roughly about 19 times more food producing animals than inhabitants. I didn't know that. So imagine that. On one of us, we get 19 animals, and I would like to pet them all. I just love little piggies and little sheepies. I would just like to have fun with them. So okay, now I'm just blushing here reading your comments. Let's focus on the class. So I'm gonna actually tell you also something about, look at this little guy. So also for the treatment of the pets, right? So we also use a lot of antibiotics for treatment of the domestic pets. So years back, I've been at a conference and I met this super cool young microbiologists, geneticists, like superstar. I don't know. She was like 13. I don't know how old she was. She was just a baby, but she was so smart. And she was telling us about this study that she has followed and completed. So where the dogs were tested for VRE, and so the dogs that live in house with people had VRE, but also the owners had VRE. So of course, before we couldn't tell who gave it to whom, but she ran a study to see who gave whom a VRE. So was it the dogs or was it the owners who gave the VRE to the dogs? Yeah, and she actually had results that she shared with us. I will have to look up and share that with you. I was absolutely impressed. I was starstruck by her, and now I follow her and her cat on Twitter. And she may have said something bad about the dogs because she's a cat person. We are not going to say anything to anyone. So there is a story about a very, very, very sad story about a kid in that has acquired a pneumonia, and he actually has traveled to Texas, and when he came back, was he was seen in Scarborough Hospital, and you can see for yourself the it did not end up in any way any one of us would want. But he has passed away, and then his father and his sister also developed MRSA infections. So again, you would think the US is a highly developed country. They have more means than many countries that will come to our minds, but this is something that has been obviously prevalent in the states, and they have quite a high rate of MRSA in the states, and something that is not really made very it's there. It's not, they're not hiding it, but I don't think it's actually being covered in a great detail that we would need to know. But Leonard, that's what I want. I would like to not to have to pay for my funeral. Just get a bunch of cats and problem solved. Done. Not the house cats, the pneumonia case, right? Yeah. So, and then we have another case here from that actually got imported from India. So with CPE is something that we had originally thought it's being imported to us, and as you know from me talking to you guys, it's we grow now our own. We have evolved in such ways that we are growing our own CPE in our hospital, so we have made up our own recipe. But this particular lady, she actually had a surgery and she broke her leg and had to have a surgery in India. And when she came back, she was admitted to a hospital, and they found that she had actually two different types of multi-drug resistant organisms. So she had Klebpneumo and Acinetobacter baumannii. And so that's not unusual. That's quite common, actually. We find mostly E. coli and Klebpneumo in our patients. So that's not unusual. I've seen so many patients that had both in one of my previous hospitals, because again, it's mostly the population that we served was people coming from sub-Indian Indian subcontinent. These guys are talking about cats. I thought there was something going on about my CPE case, but no, they're talking about cats eating people. That's okay. Um, So what sadly actually has come out of this case is that not only this patient had been identified with the CPE, it's also this it spread to 5 other patients in the hospital. So which is interesting actually how some of them got one microorganisms and other got the other. So it just kind of tells you that there is also the host's response that does play a role as well. So you will see that some people got the Acinetobacter and the others got the Klebnum. I can't look at these comments here. It's just distracting me. All I want to talk now is the cats that eat you while when you pass away. And whether they have VRE or not, I wouldn't know, but they're just adorable. So if you access Public Health Ontario's website, you will see that there is some framework established to push for the antimicrobial stewardship across the province, and that's what it's expected from us to follow that. So they have it broken down into priorities, but they also have it broken down into kind of based on ease, on what can you implement easier, so you can break it, filter it however you want once you land on that antimicrobial stewardship page for them. But they want us all to use, of course, the antibiograms, and that's already available, so it's not that difficult to use. They also would like to see more of that dose optimization and involvement from the physicians in terms of how do we prescribe and the quality of the prescriptions. So again, it's mostly this is for all levels of healthcare. So we do have, I would say, relatively good grip in most of the larger centers in acute care settings. Our biggest problems are actually the community. If you look back into that percentage that I was showing you, that we are prescribing about 92% of all antibiotics in the community. So there is something to be done within the dentistry and the general practitioners that are prescribing. No worries, Suganda. Just yeah, so we're over the time, so I will just wrap up the next 3 slides, and then um, I will send you guys an email to just confirm for next Friday. We will briefly meet to go over some of those if you end up having any questions for me. But have a good night, Suganda. So again, as I said, Accreditation Canada requires all our hospitals to have a program in place, and it has to be implemented and fully functioning. Otherwise, their accreditation is at risk. And it is important that the programs are, for sure, I will. uh, that involves the pharmacist, ID doc, and of course us, but also you may also include your surgical leads who are prescribing the prophylactic medications, or you may have your micro lab involved as well. So sometimes in the bigger centers you will find that more people are involved and taking part, but as I said, it's depending on the facilities. So you want, again, to focus on these recommendations that are in line with Public Health Ontario as well, but you want to make sure it works for your facility as well. And so I'm just going to say this, there is this Spectrum tool. I have been actually in part involved with development of this tool. It's an app. You can download this on your phones and just pick a center that is close to your facility or that you may be gravitating to. So once you download the app, this is kind of how it looks. Oh, this may be better. So And then you can pick your guidelines. And then you can either look at by category. I don't know if you guys can see this, but there is like bloodstream infections. And then you also can look into the pathogens. So you can look at broken down by actual microorganism. And if you say pick Campylobacter, so you can see what kind of precautions and then general susceptibilities that are already there from that you know they're susceptible to these antibiotics. I don't know if you can see, I'm trying to show you, but I don't know if you're seeing well here on the screen. And then some of the associated syndromes and additional information. But any microorganism you pick, you will have what kind of precautions you need, and also what are the recommended treatments based on the actual microorganism. And then you have it filtered through the antimicrobials. So I don't know if this works. Me. There, that's better. I am not reading what I'm reading here, am I? I don't want to know. I just, my heart, my soul.
Not sure what you're referring to. You gotta explain. There's many conversations going on.
Oh man, it was like I left it off when we were talking cats. Now we are treating husbands. I don't know what's happening.
Well, I was talking. So basically, like whenever I get sick, he'll get sick with me. Obviously, like husband, you're sleeping in the same bed, right? So we kind of get sick together. But anyway, so I had my own meds and he had his, but then he wasn't able to go to the doctor to get his. And I was very resistant, like I said before, that I'm very, very resistant to my meds. So I have to get them changed very often. Every like 5 or 6 days needs to be changed. So because he wasn't able to go for 1 or 2 days, he used mine, but then he also went to the doctor and the doctor prescribed him the same meds because those meds work for him. He hasn't used many meds throughout his life. So they work for him, but I'm resistant to them. So he has to keep changing my meds. So he'll change it like 2 times. So for 3 weeks, I'll be on meds, on 3 different meds for 7 days. So I let him use it because I knew that that worked for him because he's gotten sick before. And that's the same medication, same dose, same everything. That's why he used it. But then he also went to the doctor and he got the same prescription because I knew that's what he always gives them. They always check the history of it and they see this worked for this person and they give the same one. So I already knew, like, because I'm a nurse, I knew that he uses the same one. It's the exact same dosage, same thing. So I just like let him have it for the couple of days. That
Don't follow what she is doing.
No, of course not. I'm not saying that. Like, don't follow what I'm saying, but I'm saying like sometimes when you're getting to like you have no like clue what to do because all 3 of us were sick. My like 18-year-old daughter was sick and she had gotten her own prescription. I had gotten my own and I got him sick because we're all living together. So I knew which one he used. So it's like
I
at
think
least
the problem is that you're all living together. I think you need to kick your husband out.
They sound like senior citizens. They sound like the senior citizens who share medication.
Berna, I thought the same thing. I was literally like, listen, when we get sick, it's like you stay away from us. We stay in a separate room and you stay in a separate room. Like, don't touch us at all. Don't come near us. Because when she gets sick, I get sick. Like, my daughter gets sick, I'm sick. And then if I'm sleeping with him, he gets sick. Everybody gets sick.
So like, Marina, maybe we just lock him in a basement.
There is no basement. I live in a townhouse and there's no basement for me to lock him in. Okay, if there was one,
I'm sure there's a linen closet that he can fit in.
My God, it was so funny, honestly. Like, I couldn't even handle myself. I was just like, well, you're going to have to take this because this is not working for me. Here. And I gave it to him. don't anybody else do not take this as advice.
No,
It's just
this
advice
is
people,
what we
but it
don't do. Yeah.
Yeah, I just knew that it worked for him because that's what he always used every single time I got sick. That's the only difference.
Oh my gosh. You know what? I don't know. I find like luckily we don't get like we first of all we don't have any offspring to bring stuff into house. I find anytime you have the snooty kid, you are exposed to God knows what not. So we don't have that. We don't have pets. So no, we are lingering in our house. So it's between the two of us, and we have not been healthier since COVID started. Like we have not come down with anything. So it's pretty good. So it's good
Yeah,
going on
nobody
our
got the
part.
flu. There's like no flu happening, and I get sick
No,
like 3
there
times
was
a
no
year.
flu at all. Yeah.
I didn't even get sick. I was so surprised. 3 times a year. Usually, whenever the weather changes, I'm down. Like literally, I'm just down with like a cough and a cold and
And
everything.
if you have kids that are in school, forget about that, right?
Yeah,
They're
that's
coming
worse.
home, and that's exactly what happens. And the masks do work for sure. You know exactly, right? Now it's a little bit concerning. Like I have to kind of look at myself and thinking, once these masks come off, everyone's gonna know I have a mustache now. So yeah, we had one reported case in Ontario in 2021 of flu. One.
Yeah, I thought it was 0. It was
So
0.
we had one reported case. Yeah.
Mm.
So is everyone good? Everyone feeling well? How are you guys feeling about the exam? Is everyone okay, or are you guys stressing? What's happening? Good night, Burnett. Okay, not ready. Okay, so I'm gonna send you guys email to all of you, and then if you don't mind, just when you respond, send me one question before, say, let's say Thursday noon. I get questions from you so I can respond, and then Friday 6:30 we meet and I just help you through. It's a lot of reading.
Cornelia,
Yes.
do not forget to email me.
You're out of
Just
my
make
circle
sure
of
I'm there.
friends.
Just make sure I'm there in it. Leonard's able to email me. Make sure you
If it
message
wasn't
me.
for Leonard, you would be completely excluded.
That's what I'm saying. I'm like, Rosemary needs to like forward me all the emails. So make sure you email me
It's a
too.
good thing Rosemary is looking out for you. Thank you, Rosemary.
Yes.
Yeah, see, she's a good girl. She works with us. All right, so let's wrap it up for tonight. Then I'm just gonna say thank you, guys. Thank you for attending. Thank you for being kind to me and putting up with me. And I'll see you on Friday. Good. I'm glad you had fun with all the cats that are eating us alive or dead.